Bismillahirrahmanirrahim. In GIT, yesterday we discussed diseases of the salivary glands, and today we will discuss diseases of the oral cavity. In the oral cavity, we will discuss some important inflammatory lesions, precancerous lesions, and then carcinoma of the oral cavity. This slide shows the learning objectives for the today's lecture. We start the today's subject with the diseases of the teeth and supporting structures. In this we will discuss three important diseases briefly: caries tooth, gingivitis and periodontitis. Dental caries may be defined as focal degradation of tooth structure. The cause of dental caries is mineral dissolution by acid metabolic end products from bacteria present in oral cavity. These bacteria are capable of fermenting sugars. Dental caries is the most common disease of tooth worldwide. It is the most common cause of tooth loss before 35 years of age. Poor hygiene increases the rate of dental caries. Processed food containing large amounts of carbohydrates set the stage for caries. This slide on the left side shows the diagrammatic picture of a normal tooth with different labeled structures, while on the right side we can see the gross appearance of a tooth which is badly affected by dental caries. Gingivitis may be defined as a condition in which there is inflammation of the soft tissues that surround the teeth. The disease is most common in adolescence but can occur at any age. It results from lack of proper oral hygiene and characterized by development of plaques and calculi around the teeth. The chronic condition is characterized by redness, edema, bleeding and loss of soft tissue surrounding the tooth. Regular brushing, flossing and hygiene visits result in healing of gingival tissue. The picture in this slide reveals the gross appearance of the gingivitis. We can see that the gingival mucosa is markedly affected by gingivitis and appears pale. Periodontitis is defined as the inflammatory process that affects the supporting structures of the teeth, like the periodontal ligaments, alveolar bone and cementum. One of the very important factors in the pathogenesis of periodontitis is the poor oral hygiene. Dramatic shift in the type and number of the oral bacteria is the main cause of periodontitis. The main pathogenic organisms are the anaerobic and microaerophilic gram-negative bacteria. Periodontitis is also associated with systemic disorders like AIDS, leukemia, Crohn's disease, diabetes mellitus, Down syndrome, sarcoidosis, and syndromes associated with polymorphonuclear defects. Periodontitis can lead to infective endocarditis, pulmonary and brain abscesses, and adverse pregnancy outcome. In the oral inflammatory lesions, we will briefly discuss aphthous ulcers, herpes simplex viral infection, and oral candidiasis. Now, aphthous ulcers are extremely common superficial ulcerative lesions of oral mucosa. They are more common in the first 2 decades of life. Aphthous ulcers are painful, often recurrent, and tend to be prevalent in certain families. On examination, they are single or multiple shallow hyperemic ulcerations covered by thin exudate and rimmed by narrow zone of erythema. Microscopically, the underlying inflammatory infiltrate initially is mononuclear. If there is secondary bacterial infection, then there is influx of the neutrophils. The etiology is obscure, and usually the aphthous ulcers resolve in 7 to 10 days. The treatment is symptomatic. The picture in this slide shows two aphthous ulcers on the inner aspect of the lower lip mucosa, and we can appreciate that the surrounding mucosa is erythematous. Coming to herpes simplex virus infections, most cases are caused by HSV1 in the oral cavity and a few by HSV2. The primary HSV infection is usually asymptomatic. About 10 to 20% primary infection presents as acute herpetic gingivostomatitis with vesicles and ulcerations in the oral cavity. The associated complaints and clinical features include lymphadenopathy, fever, anorexia, and irritability. On examination, clear oblique serous fluid-filled vesicles are seen ranging from few millimeters to large bulli. The vesicles often rupture, leaving painful red rimmed shallow ulcers. Microscopically, there is intracellular and intracellular edema yielding clefts, a phenomena known as acantholysis. There are eosinophilic intranuclear viral inclusions and several cells fuse to form cells known as multinucleated polykaryons. The vesicles and ulcers usually spontaneously heal in 3 to 4 weeks. Candidiasis is the most common fungal infection of oral cavity. Although Candida albicans is normal component of oral flora in 50% of the population, the development of infection depends upon the immune status, type of strain present, and the composition of the oral flora. There are three major clinical forms of oral candidiasis, namely the pseudomembranous, the erythematous, and the hyperplastic types. Of these, the pseudomembranous is most common and is also known as thrush. It appears as a superficial, curdy, grey-white inflammatory membrane that can be readily scraped off, revealing underlying erythematous inflammatory base. In mild cases of immune suppression, the disease remains superficial. However, in debilitated and severely immunocompromised or immunosuppressed individuals, deep-seated infection can occur. This slide shows oral candidiasis. We can see that the tongue surface is covered by oral thrush, appearing as a white curdy membrane on the tongue surface. The fibrous proliferative lesions of the oral cavity include the fibroma and the pyogenic granuloma. Fibroma, also known as irritation fibroma, is usually caused by irritation, or it can be caused by some unknown mechanism. It usually occurs in buccal mucosa along the bite line or on gingivo-dental margin. Microscopically, it is a nodular mass of fibrous tissue covered by squamous mucosa, showing infiltration by few inflammatory cells. The treatment is complete surgical excision. The picture in this slide reveals the gross appearance of a fibroma. Pyogenic granuloma is also known as pregnancy tumor. It occurs in the gingiva of children, young adults, and especially pregnant women. Grossly, it is a pedunculated red to purple ulcerated lesion. Microscopically, it is a highly vascular proliferation like granulation tissue covered by ulcerated mucosa. Pyogenic granulomas either regress or they undergo fibrous maturation and may develop into peripheral ossifying fibroma. Complete surgical excision is the treatment. The picture in this slide reveals the gross appearance of a pyogenic granuloma, appearing as a erythematous hemorrhagic exophytic mass arising from the gingival mucosa. Now we come to the precancerous lesions. There are two important precancerous lesions in the oral cavity, leukoplakia and erythroplakia. Leukoplakia may be defined as a white patch or plaque that cannot be scraped off and cannot be characterized clinically or pathologically as any other disease. It usually occurs between 40 and 70 years of age with a 2:1 male preponderance. Approximately 3% of the world population have leukoplakic lesions, out of which only 5 to 20% are premalignant. All leukoplakic lesions be considered precancerous until proved otherwise on histologic evaluation. The favored locations are buccal mucosa, floor of mouth, ventral surface of the tongue, palate and gingiva. Grossly, leukoplakic lesions appear as solitary or multiple white patches or plaques with indistinct or sharply demarcated borders. Microscopically, there is hyperkeratosis over thickened but normal looking epithelium which can be markedly dysplastic, merging with the changes of carcinoma in situ. The more severe the dysplastic changes, more is the subjacent inflammatory infiltrate of lymphocytes and macrophages. This slide shows a small, almost rounded leukoplakic lesion. The picture in this slide shows a large leukoplakic lesion with focal irregular borders. The picture in this slide reveals the histologic appearance of leukoplakia. We can see that the epithelium appears moderate to markedly dysplastic. Erythroplakia is defined as a red, velvety, possibly eroded area within oral cavity that usually remains level with or slightly depressed in relation to the surrounding mucosa. Erythroplakia incurs a much higher risk of malignant transformation than leukoplakia. It is usually found between the ages of 40 and 70 years with a male to female predominance of 2:1. Erythroplakia has multifactorial origin, but the use of tobacco is a major factor. Microscopically, the epithelium is always showing dysplasia or carcinoma in situ, or there is invasive carcinoma in the surrounding tissue. Intense inflammatory reaction and vascular dilation in the subepithelial tissue accounts for red appearance of the lesion. The picture in this slide reveals erythroplakia of gingival mucosa. If we concentrate, we can appreciate that the lesion appears slightly depressed than the surrounding mucosa focally. Now we come to squamous cell carcinoma of the oral cavity. Squamous cell carcinoma accounts for 95% of the oral cancers. The remaining are mostly adenocarcinomas of the salivary glands. There are about 45,000 new cases annually in USA of oral squamous cell carcinoma. It is an aggressive epithelial malignancy. Oral squamous cell carcinoma is the sixth most common neoplasm in the world today, usually diagnosed in advanced stage, thus markedly reduces the long-term survival, which is less than 50%. The development of multiple primary tumors or a new primary tumor after the initial tumor further reduces the long-term survival. The patients who survive 5 years after the initial tumor have a 35% chance of a new primary. Early detection of all pre-malignant lesions is critical for long-term survival of these patients. The development of multiple primary tumors or a high rate of second primary tumors suggest field cancerization. Now, what is field cancerization? This hypothesis suggests that multiple primary tumors develop as a result of years of diffuse mucosal exposure to carcinogens such as alcohol or tobacco. The pathogenesis of oral squamous cancers is multifactorial. However, two distinct pathways have been identified. One involving exposure to carcinogens, and number two related to infection with high risk variants of human papilloma virus, i.e. HPV. Oral squamous cancer is a disease of middle-aged men, especially who are chronic abusers of tobacco and alcohol. The tobacco and alcohol are common risk factors in oral cavity, whereas in oropharynx, HPV infection is present in about 70% of the cases. Continuing with the pathogenesis, family history of head and neck cancer or genomic instability is a risk factor. Then exposure to actinic radiation and pipe smoking are the predisposing factors for lower lip cancer. Chewing of betel nut and pan in India and parts of Asia is a predisposing factor. Chronic irritation of mucosa is a promoter and not direct antecedent of oral cancer. Now coming to the molecular biology of squamous cancers. It is a multi-step process involving sequential activation of oncogenes and inactivation of tumor suppressor genes. Loss of chromosomal regions of 3p and 9p21 results in inactivation of p16 gene, an inhibitor of cyclin-dependent kinase, leading to hyperplasia and hyperkeratosis. These changes are more common in human papilloma virus associated squamous cancers. Loss of heterozygosity at 17p along with mutation of p53 tumor suppressor gene results in dysplasia. Alterations and deletions on 4q, 6p, 8p, 11q and 14q act as predictors of progression to frank malignancy. Amplification and overexpression of cyclin D1 gene on chromosome 11q, 13q confer the ability to invade in a certain clone. Now coming to the morphology of oral squamous cancers, the tumors may arise anywhere The common sites are ventral surface of the tongue, floor of mouth, lower lip, soft palate and gingiva. On gross appearance, the early or smaller lesions appear as raised, firm, pearly plaques or irregular, roughened or verrucous areas of mucosal thickening. The larger lesions create ulcerated and protruding masses with irregular, firm and indurated or rolled borders. Histologically, these cancers begin as dysplastic lesions which may or may not progress to in situ carcinoma before invading the underlying tissue. The fully developed squamous cell carcinomas vary from well-differentiated keratinizing to highly anaplastic tumors, sometimes with sarcomatous change. In the well-differentiated tumors, we can see groups and sheets of squamoid-looking cells with hyperchromatic nuclei with focal areas showing keratin pearl formation and keratinization. This slide shows the histologic appearance of a squamous cell carcinoma. We can see small and larger groups of squamoid-looking neoplastic cells with focal areas showing keratinization and keratin pearl formation. Now coming to the spread of the oral cancers, local invasion always precedes distant metastasis. The regional metastasis is in the cervical lymph nodes and distant metastasis to mediastinal lymph nodes, lungs, liver and bone.